Before I start my presentation, I know I was already introduced, but I kind of wanted to give you a very short career journey to kind of tell you how I ended up where I ended up. So since I know there's a lot of graduate students here and postdocs, and so maybe that can help you. I need to speak louder? Yeah. Okay. Maybe I'll just use the microphone because I don't really have a really loud voice. Okay. So I was born and raised in Mexico. I came to the U.S. when I was 16. We moved to New Jersey because my dad is a pastor, and he was given a church in Brooklyn, New York, and so, but he didn't want to live in New York City, so he decided we were going to live in New Jersey, and so that's how we ended up in New Jersey. When I came here, I didn't know any English, and so I had to start from zero, basically. Thank goodness I had a couple of years of high school, and so that helped me learn and prepare for my bachelor. And so then I went to NJIT. I got a bachelor's and master's in applied math, and I was pretty sure I was just going to be a mathematician, and by that I mean I was going to be a professor and I was going to teach math. That was kind of my view of the world, because the only thing that I really enjoyed was mathematics. And but then during my bachelor, I was exposed, I guess, or someone told me about this REU program. So I applied for an REU program, which was MTBI, and that was Mathematical and Theoretical Biology Institute, and which used to be at Cornell. And so I went to the REU program, and I think that's when kind of my entire career, my entire view of my future shifted. Dr. Carlos Castillo Chavez was the director of that institute, and that's when I became aware of the intersection of epidemiology and mathematics. And so that was super exciting to me to combine something that would be useful for, for the world, basically, because public health is an important topic, and then also combine my love for mathematics. And so that was pretty transformative for me. And so I was also sort of like brainwashed to go and get a PhD. So I did that. I applied for a PhD program, and I went to the University of Iowa. And so while I was at the University of Iowa pursuing my PhD, I was invited by Dr. Castillo Chavez to go to Los Alamos for an internship. So it was going to be a one-year internship. That was in 2003, and then after the internship, I was going to go back to Iowa and finish my PhD and then figure out what I was going to do with my life. But during the internship, I really liked working at Los Alamos, and by the end of the internship, one of the scientists that was working with us asked if I wanted to continue working there. And so I said, okay, sure, why not? The pay was a lot better, actually, from Los Alamos than from being a graduate student at the University of Iowa. And so I stayed there as a graduate student, and then, the rest is history. I've been there since, and I'm now a chief scientist, but I went through the whole, postdoc and staff member, and now a chief scientist. But I think my kind of takeaway from this is that you should always try to, I think that there's many different things I feel that are a common theme across my career journey. One is the value of mentorship and how mentors can create connections and opportunities for you. So I think, always try to find mentors. Even now, I still have mentors that are helping me with my decisions and everything. The second one is the importance of networking and being open to opportunities, because I was open to going to an REU program. I think that opened up a lot of different opportunities for me, and then I was open to go to Los Alamos for a year, and that opened, other opportunities for me. So try to be open to new opportunities, and if you don't like them, you can always go back to what you were doing before. So, oh yeah, and so one other thing I wanted to say about Los Alamos, which I also kind of mentioned during the breakfast with the folks that I was sitting. So before Oppenheimer, like when I would travel around the world, or and I would, people knew that I lived in New Mexico. People would always bring up Breaking Bad, and they're like, oh, Albuquerque and everything. But now I think, thankfully, because of Oppenheimer, I think the movie Oppenheimer, I think more people are familiar with Los Alamos and the fact that Breaking Bad is not the only good thing that came out of New Mexico. So, okay, anyway. So now so let me start with like some motivation that, obviously the COVID-19 pandemic was a big motivation for the type of work that we're doing, but a couple colleagues of mine, Kelly and Tammy, we were given funding to interview scientists around the globe, and so we interview about 80 scientists from all over the world, including Europe, Asia, Africa, and South and North America. And we are actually publishing a paper that kind of highlights these interviews, and then also some of the challenges with epidemic modeling during the COVID-19 pandemic. And there's a lot of stuff, you can kind of see many different challenges that people face during the pandemic with data, bureaucracy, and many other things. But the thing that I want to highlight is when it comes to modeling, there were major themes that we heard from modelers around the globe, and that was the need for more accurate models, because a lot of the modeling frameworks and the modeling capabilities that we had didn't really have kind of the nuances and the complexity of the world, so we weren't really able to accurately forecast and understand the dynamics, as behavior, and also just differences, sociodemographic differences, and many other things. The other thing that I wanted to highlight is the need for more complexity, because we're mathematicians, we try to always go for tractable applications and models, and so if we can solve them numerically, manually, we don't necessarily want to go to the numerical kind of approach, and so, but the world is so complex, and so we need more complex models to capture the disparities that we experienced during the pandemic. And so some of the themes that I feel like we're trying to achieve through this work is, enhancing model complexity, accounting for population heterogeneity, which I will show in just a minute. Also foster interdisciplinary collaborations, because we as mathematicians don't know everything, and there's a lot of like social aspects that need to be incorporated in our models, and so collaborating with other people is important. Integrating ethical frameworks. I also been working with some people in Australia and New Zealand, and that are ethicists, and they're kind of opened my mind about ethical frameworks that basically balance public health impacts, societal benefits, and also they lead more towards equity. And this is from a modeling perspective, our main outcome is always like the public health impact, without really taking into consideration the social impacts, and how there's certain communities that are going to struggle with certain mitigation strategies. So trying to incorporate ethical frameworks into our models is important. And even though we're not quite doing that yet, because this is just an initial project or preliminary results, I think we are trying to move towards the ethical framework kind of idea. And then and ultimately for me, it's important to deliver actionable decision support. I work, or I used to work, with the White House and the CDC with pandemic response, and so the national labs are some of the modeling component of the federal government, And so for us, not just modeling something for the sake of publishing a paper, but actually for influencing policy and mitigating impacts is super important. So one ultimate outcome of our work is to deliver actionable and accurate and timely decision support. So the challenge, I don't know, I assume that there's a lot of different areas here, not just mathematical epidemiology, and so I just wanted to kind of give you a highlight of where this community lives before I kind of go into what we're doing. So for your reference, most EPI models use the compartmental modeling approach, which assumes homogeneous mixing. And so you use basically a system of differential equations where you put the entire population into one of these compartments, and you then estimate different rates of movement between the different compartments, and basically then you can kind of solve that system of differential equation for a given set of parameters, and then you get your epidemic curve. And so what these models are basically capturing by assuming homogeneous mixing, which is kind of shown in this figure, is that everyone is connected with each other. And so imagine right now if I was trying to simulate the spread of a virus or a pathogen here within this room, it would make the assumption that I had contact with all of you equally, even though I only sat in a table with a few folks and I've only talked to a few folks. And so this homogeneous mixing is not really capturing the heterogeneity within our world. And so there's other kind of the second level of epidemic modeling, which is meta-population models. And so they kind of break two different communities. So for example, two different counties, they assume that everyone within each county mixes homogeneously, but across the different counties, they mix heterogeneously. And so that gives you a little bit more nuance into what's going on in the pandemic, and you can kind of see how the disease for this particular, the epidemic curves for this particular kind of scenario kind of give you, it doesn't tell you that everyone will get infected and everyone will recover, but you know, a proportion of them get infected and recover. And so, but what we need is a little bit more sophisticated models that really capture the individual differences that actually lead to health disparities. And when you have not just the spatial differentiation, but you also capture the individual differences, then you can kind of see how different states and different communities and different age groups and different everything will have a very different dynamic than if you assume like, you know, equal kind of or homogeneously mixing assumptions. So now let me move into the to what we're doing with modeling health equity. As I mentioned, the COVID-19 pandemic was one of the major motivations for us to work in this. And as you know, a lot of the Latinx, Black, and American Indian communities were disproportionately affected during the pandemic, and not just for hospitalizations, but also for deaths and incidents and everything, and societal impacts too. And so here I'm showing, because we live in New Mexico, we use New Mexico a lot for a lot of our studies. And so you can see, I don't know if it's easy to see, but this black line is the Native American population. This pink one is Hispanic. Then there's white, and these are other communities. And you can see that at the beginning of the pandemic, the Native American communities were hit super hard, and you can see that even though they only make about 11% of the population in New Mexico, they were accounting for more than 70 or 60, more than 60% of the cases at the beginning of the pandemic. And so our models, the models that we were using during the pandemic were not, we were able to kind of see that there was higher higher incidence rate in certain areas, but we couldn't really pinpoint it to which communities. Obviously, if you make an assumption about, if you live in this area, maybe that you're more likely to be Native American, and so we could make inferences about the fact that Native Americans were being disproportionately affected, but we didn't really have the tools in our models to actually capture it in a more systematic way. So our overarching goal of this study is to basically show how sociodemographic heterogeneity and exposure risk as drivers shape the population disparities. And in particular, we're interested in kind of capturing racial and ethnic differences, which is what's going to be our major contribution. So now what we're trying to do is capture the intersection of race and ethnicity and other drivers. So one of the drivers that we wanted to capture is household size, and so here you can see, for example, different mean household size for New Mexico across different races and ethnic groups. And so you can see that, for example, Native Americans have one of the highest, and this is just the mean, but later I'm going to show you the distribution. And there are several studies that have shown that household size is a key factor in disease transmission, and so that's one of the drivers that we wanted to capture and see how that is impacting certain communities. The other driver that we wanted to capture was employment. And so here, this is actually New York, and you can see employment in hospitals, for example. Here, there's a higher percentage of people in New York with Hispanic and Black backgrounds. And then the other one here, you have basically restaurants, and so also a lot of Hispanic and Asian people working in restaurants. And then you have nursing and residential care facilities, a lot of Black employees, and then finally professional, scientific, and technical services. You have Asian and white, for example. And so we wanted to see how the different industries and employment and exposure contributes to disease transmission and risk. And then finally, the third driver that we wanted to capture was the student-teacher ratio. And these are all kind of hypotheses. We were hypothesizing that the intersection of race and household size, and the intersection of industry or employment type and race and ethnicity will contribute to higher proportion rates. But you will transmission rates. But then I'll show you then the results later. And so for student-teacher ratio, this is Florida, and basically you can kind of see. Okay, so this is the student-teacher ratio, and this is the percentage of Hispanic students in Florida. And so the correlation is not super high, but we wanted to see if that was also contributing to transmission rate. Okay, so the model, we use a lot of computational models in Los Alamos, and so we've had these models for I don't know, over 20 years, but our models were previously had not captured race or ethnicity, and so that's something that we just added to the models. And then we also added more complexity when it comes to worker, industry, and exposure. So we're trying to differentiate between just mixing with other coworkers at a work location versus having more interactions with the public or higher intensity with certain potentially infected people. So for example, in hospitals, people have more intense contacts, quote unquote, but if you work at a restaurant, you have, or if you're a bus driver, you have a lot more contacts with the general public. And so we were able to kind of add those differences in the model so that we can better account for exposure risk. And for the schools, we're also kind of adding a little bit more complexity when it comes to like different grades and different student-teacher ratios so that we can hopefully understand their impact on disease transmission. So once you have the population, which is one of the most important aspects of your model, then we have the locations. And so for this particular model, we're not following each person through every single minute that they run around their communities throughout the day. We only have like daytime and nighttime. And so this actually gives us a lot more computational advantages because these models, we're running these models for like the entire United States, and that's 320 million people. And if you do this, like if you're following them on a minute by minute basis, it would take a lot, even if you're using a large clustered or a supercomputer or even cloud computing services, it would be a lot. So we're just doing daytime and nighttime, and so we see what different contacts they had during the day and just estimate probabilities of transmission, and then nighttime, and then you kind of do a lot of computations throughout the day, per day. And then the final kind of piece of the model is the transmission model. And so basically you have to put information and parameters about, how long they're going to be infected for, and also in this particular studies that I'm going to show you, we're not including any mitigation strategies, but we also have a lot of like mitigation strategies, vaccination, and face mask usage, and other kinds of stuff. And so, that goes into this part of the model. And then finally, you can come up with an epidemic curve, and then you can actually account for the impact in each group. So, so we had 4 experiments. And so the first experiment was in New Mexico. We just wanted to understand household size. And we couldn't really, we did come up with different ways that we could compare this with something else, but it was really hard because if you do random let me show you maybe the next one. So for work, the 2 different test cases that we had was random work assignments. And so we assign, I showed you before the breakdowns for the different races and ethnicities, but we said, what if everyone has the same probability of working at a hospital or at a restaurant or at a professional setting? If you make it randomly, then you're able to capture what is the impact of the actual distribution that you have and the actual breakdowns. But we couldn't do that for household size because then we would need to like change the races of the people in the households in order to see what would be the impact of a random household size assignment, given the distribution. So anyway, so we just decided to keep it simple, and so that one is only going to be one type of model. And then the other model, which is the school experiment, was to assign the state average student-teacher ratio versus the county student-teacher ratio. And so when you average it for the whole state, you're actually getting rid of the heterogeneity across the state, because there might be counties that have a high student-teacher ratio, and other counties that have a very low student-teacher ratio. And so when you use the average, you're kind of like removing the heterogeneity, and so then you can compare it to the county student-teacher ratio, and then measure the impact. Okay, so these are the results for New Mexico, and so just to remind you, we're trying to understand household size and its impact on transmission rates for different communities. And so here, this is just kind of like an overall summary of the results. And so here's the average epidemic curve. We ran, as I think I forgot to mention that, we ran all the models for 120 days and performed 10 realizations per experiment. So this is the average of the 10 experiments, and the reason why you see a lot of variability, well, one is because it's an agent-based model, so there's stochasticity, and so you are flipping a coin a lot of times. And then the other reason is because we have weekends and weekdays for the agents. So during the weekends, people don't go to work or they don't go to school, or a small proportion goes to work, but most people don't go to work, and all the kids don't go to school, and so that's why you see a lot of variability. Anyway, so here's the epidemic curve, and this dashed line corresponds to the snapshot of the heat map that I'm showing here of New Mexico, which was day 90, and then here's the different proportion infected, and because we were plotting race, then the Hispanic population are captured either under other or multi. And so you can see from here that the spatial heterogeneity, the Navajo Nation and the Native Americans are mostly in the upper left corner of New Mexico, and so you can kind of see the higher infection rates, which is consistent with what we saw during the pandemic. And so because they have higher household size, they are showing that that they had more disproportionately higher rates. Okay, so now when it comes to kind of measuring the impact of household size and exposure risk, so here's the distribution of household size by two different groups. We have the Native Americans and white, and you can see that the distribution is way tighter for white communities than for the Native American communities. They're wider spread, and they have more people with household size that are larger. And so here is the correlation between the proportion infected in a household, and then this is the mean household size among individuals in a census tract. And so you can clearly see that there's a strong positive correlation between the mean household size and the household exposure rate in each of the census tracts. And so basically what it means is that as the household size increases, your proportion of people infected in that household will increase. And so then this is also the proportion infected of Native Americans and white. So our second experiment was to try to understand this is New York City, and so we were trying to understand worker type. And so here, once again, this is just the summary of the simulations that we ran. This is the epidemic curve. Here you have a snapshot of New York on day 62, and then here you have the proportion of people infected by different race or ethnic groups. And so you do see more like high infection rates here across all racial and ethnic groups. But when we go into actually analyzing the impact of our experiments on on whether worker type is important. So here I'm showing the proportion employed in high-risk industries, and so you can see that Black people tend to be are more likely to be employed in high-risk industries, and this is white people. And then proportion infected in the workplace, you have more people there versus the white. And so this is, but I want you to focus on this plot, which is basically comparing Model 1 and Model 3. And if you remember, Model 1 was going to assign all the work assignments randomly, and then Model 3 was going to use actual data from the North American Industry Classification System and other, other types of data that give you information about about actual workers and where they come from. And so if you look at this, you can see that if we if everyone was randomly assigned what they would be working on, you would see that more white people would get infected, and then less black people would get infected. You kind of basically have a shift in impacts. And then, but if you actually look at what is happening given the actual distribution and information that we have about how workers are distributed and their backgrounds, then you can see that more workers with a black background are more likely to be infected. And so clearly this demonstrates that there is a relationship between the employment in high-risk industries and workplace exposure rate. And so you do see a higher incidence in communities of color. And then finally, the third exercise that we wanted to do is student-teacher ratio. And so these are the results for the student-teacher ratio experiment, and this is Florida. And here, if you're looking at the proportion of infected for the different races, then you can see that there's higher infection rates across the Hispanic ethnic groups. But now, if you look at the different models and also the distribution of school group size and density, they're basically identical. And even though as the school group size increases, the proportion of people infected increases. If you look at the models, they're basically identical. And so the model one was using the state average versus model 3, which was using the county student-teacher ratio numbers. And so you can see that even though more Hispanic students are getting infected, it's not necessarily the school that is contributing, it's their environment, and it could be their household or just their connections, but the student-teacher ratio alone cannot really measure that impact. And so, basically the conclusions of this kind of preliminary study is that household size was found to be a strong driver of transmission. Individuals employing high-risk industry tended to be disproportionately people of color, but then also those industries seem to have more obviously people infected. And then the school group size had minimal impact in the transmission, which was interesting because we were expecting to see more impact, but that was not the case. And so now, implications for policy, which is what we are ultimately interested in doing. So one thing is, if we know that household size is a major contributor to disease transmission, you could also think about implementing mitigation strategies or vaccination strategies that target people with higher household size. And interestingly, the state of Washington actually implemented this policy during the pandemic. They were asking people with household size to be prioritized for vaccination. And so if we wanted to have a more equitable approach, we could use this as one potential useful way to mitigate the impacts. The other one, obviously, which we did do across the United States, was to target industries with high risk, such as nurses and doctors, but we can also expand those to other high risk employment, such as restaurants and other and bus drivers and other kind of types of employments that have a lot of public interaction. And so then in terms of the school, we need to start thinking about creating strategies that maybe don't impact schools and kids, because it seems, at least from this study, that the schools didn't really have a lot of impact in the dynamics. And so finally, I want to thank the team. I had 3 graduate students that were mostly kind of responsible for doing a lot of this work. Tom, Michaela, and Joy, and then we have other people in our team that are helping with this project. And so that's all I have. And so I know it's a little earlier, but yeah, I'm happy to answer questions.